All right.
All right. Hello, everyone. Today, the topic that we're going to discuss is knowledge translation. And today we have a knowledge translation specialist. So Dr. Angela Fong is an instructor of medicine in the section of behavioral sciences at Rutgers Cancer Institute of New Jersey, with a primary academic appointment in the Department of Medicine, Division of Medical Oncology at Robert Wood Johnson Medical School. Oh my gosh. What an
It is
affiliation.
too many affiliations. And yes, my business card is insane. No, I'm kidding.
Is it in A4 paper?
It's a piece of paper that I have to hand to people and highlight no, I'm kidding.
Anyway, welcome to the show and welcome to our class. And I'm really happy to have you, Dr. Fong. So, do you want to introduce yourself to our students as well?
Yeah, I will. Thank you. So, Dr. Young, thank you very much for having me here. I'm so excited to actually talk about knowledge translation and kind of everything that goes into it, just because A, it's kind of a hot topic right now, but B, it's also, I think, a very misunderstood topic. So I'm excited to clarify for everybody. A little bit about myself. So despite my affiliations being in the US, I'm a Canadian lady. I actually did my postdoc at Queen's, so really excited to kind of be back in some ways. My training is all in kinesiology, so again, don't let my current affiliations fool you. I'm not this kind of med school type of individuals. I'm very much a kinesiology person. All of my work is focused in exercise psychology, so I've been really interested in that realm and focused. I've been actually, again, very lucky to focus on cancer prevention and cancer survivorship since my master's. So that's kind of why I'm at the Cancer Institute. It's because I'm this very, I have this kind of almost unique training in the world of kinesiology and cancer.
Mm-hmm. Yeah, that's very interesting. And throughout the interviews with other people, that's what I find that, people have really different and diverse background. It's not like they just took one path and they just followed it. They were like all over the place and they end up somewhere. Yeah, right? So yeah, I guess that's really common in academia and it's really good to know. And it's really nice to have you back because when I first got hired here at Queen's, you're one of the first people that I saw and we hung out for about a year and you left. So that was very sad. But it's really great to talk to you today. So you've talked about your research background and your interest, but can you tell us a bit more about what you're interested in exercise oncology? What kind of research are you doing currently?
So I guess what I'll do is I'll broadly define exercise psychology for how it really applies to my work. So exercise psychology has a lot of different facets. There's prehabilitation, so essentially from the moment of diagnosis, getting someone to exercise before their treatments. And then there's, broadly speaking, survivorship. The National Cancer Institute defines survivors as anyone from the time of diagnosis until the end of life. The reason for that is because you really want to have research that applies really broadly, and that really lends itself well to KT. So my work is really in the survivorship realm, but I focus on an even narrower kind of sliver of that pie. It's from the time of treatment completion. So once they're done with their chemotherapy or radiation or surgery or whatever it ends up being, once that's all finished, then that's kind of where my work intervenes. And the reason why I'm interested in that world is because and I know everyone knows this, but like technology is getting better, medicine is getting so much better. So instead of cancer being this kind of death sentence, it's actually, obviously still very difficult, very detrimental, but there is a higher chance of surviving and of living beyond the diagnosis. So because of that, we actually have this large population, for the most part, who are living with what we call like debilitating effects from the cancer treatment. I know I won't get into too many specifics, but people think chemotherapy and they're like, oh, you lose your hair and you feel sick is kind of the, I guess, like Hollywood way of thinking of it. But there's actually things like for breast cancer survivors, 5 to 10 years down the road, they experience incredible fatigue. And it's not like fatigue of, oh, I'm tired, let me take a nap, I'll feel better. Or I'm tired, let me do a quick yoga session and oh, I feel rejuvenated. It's like really difficult. Like you sleep more, you feel worse, you're not eating as well. And so for individuals like that, intervening with like a healthy lifestyle interventions like improved physical activity can actually help with those types of effects. So that's kind of the reason why I focus on that area. And then what I do specifically is I focus on physical activity behavior, again, drawing from my kinesiology background, because physical inactivity, so not meeting those guidelines, can lead to cancer, but also in cancer survivorship, we see that a lot of times physical activity levels don't even go back to where they were before the diagnosis. So if you're already low to begin with, you go even lower coming out of treatment. So that's kind of where all my work goes there. And then to draw in the kinesiology or the KT portion, so or knowledge translation portion. The reason why I bring that into my work is because as wonderful as all the sciences that we're doing, everywhere in Canada and the US, it's really not accessible to a lot of individuals. So I'm sure your students are aware of this, but you'll read research papers and they'll always have this line of, not generalizable to the broader population, or there'll be something with the data set. I know that we have this huge epidemiological data set that's specific for cancer survivors in the US called the SEER data set. And even that data set has issues. There's not a lot of Black or African Americans or individuals who are Hispanic or Latinx. And so it's actually still not representative of the greater population. And so they'll say like, more work is needed. And so where KT kind of fits in that area is actually finding where more work is needed and also figuring out why it is that maybe individuals aren't signing up for the studies. Is it the research question? Is it the way it's presented? And then also taking those findings and making them useful. I always tell people, information is kind of the lowest form of behavior change. So, Young, if I hand you a paper that says, physical activity leads to all these benefits, you'll read it and be like, that's really interesting. But that doesn't mean you're hopping on a treadmill or you're going out, cross country skiing right after you read the paper, right? That's not enough to make that connection. But if we take that same information and we change it into, let's say, a knowledge product, so it could be like an infographic, a mass media message, a really good TikTok video, or like has to be really, really good. And we kind of disseminate it that way, that can actually be a better way to increase or get our message across. So it's kind of like incorporating that science into translating from the dense product of a paper into something more bite-sized and manageable.
Right. So I think you've covered a lot of important topics already. But
that's it. We're done now.
Yeah, it's all good. But yeah, when we talk about knowledge translation, so you've touched on, accessibility and producing knowledge or turning scientific knowledge into something digestible and more biteable, or more palatable, and also that that informs our, sample recruitment and data collection process as well. So, in essence, how would you define knowledge translation?
Great question. So I'm actually gonna do the whole, it's not kosher, but I'm gonna first read you the CIHR definition of knowledge translation, and then I'll kind of break it down from there. So it's off of their website. It says a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians, provide more effective health services and products, and strengthen the healthcare system. So that is a lovely definition. But my criticism of it is that it's very broad and doesn't really get at the essence of what KT is. So they do hit it on the head. It is a lot of those things. But broadly, big umbrella kind of speaking, KT is essentially the systematic approach to take scientific information and then turn it into something that's either additional knowledge or disseminated to the knowledge user. It's an iterative process and it involves a lot of individuals. So kind of, I'll give you an example. For instance, a systematic review is actually considered part of KT, because what you're doing is you're actually taking all of the literature that's out there and systematically going through it and saying, okay, here are these studies that actually meet a certain criteria, and here's like the level of bias. And of these studies, this is what we broadly found. So we can say that this type of intervention can be beneficial for for a target population. So that's one form. That's what we call again, like knowledge synthesis, knowledge creation. There is a broad sort of framework that a lot of KT scientists in Canada especially use. It's called the knowledge to action framework. And in that framework, they kind of have like a funnel where you break down the knowledge. And then at the bottom of the funnel, that information gets turned into something that's useful. So in KT, that's where the real kind of magic happens, is like you synthesize the information, we have the systematic review. Now let's figure out what our course of action is. And that's where KT fits in with the science. So you do things like you work with the end knowledge user. So for us, that means the population that you're trying to impact. It could be the general population, so trying to get more Canadians active. It could be a very specific population, for instance, getting more cancer survivors active. But again, and you know this as well as I do, these populations are diverse on so many different levels. A cancer survivor that lives in Kingston is very different from a cancer survivor that lives in Thunder Bay. I would know this. I've been to both of those cancer centers and their needs are just so incredibly different. In Kingston, you're very lucky because the LIN there has a lot of programming that's very cancer specific, things even like dragon boat teams in the summer that survivors can join. Whereas in Thunder Bay, the issue is, there's a lot of distance between the towns. And just because you're treated at the cancer center in Thunder Bay doesn't mean you live in Thunder Bay. You actually may live 3-4 hours outside of Thunder Bay. So for me to find a physical activity program that's useful for that cancer survivor is very different. So essentially you're taking that knowledge and you're adapting it based on set criteria. And you're including, again, the knowledge user and then individuals that we call key stakeholders. So this could mean anyone in terms of researchers, community-based partners, so the individuals who are running the programs, patient advocates, healthcare providers, administrators are really important. And the ultimate goal, and similar to epidemiology, is to one day impact policy. That's, I think, always our goal with the research that we do. And so that is a both broad and compact version of KT.
Wow. Yeah. So, very interesting. So you provide a criticism on the CIHR definition of knowledge translation, that it's too broad. It's touching on everything that are important, but not really getting into what really KT is and why it is important. And based on your discussion, it feels like, we have this hierarchy of evidence, and at the top we have systematic review, and we have lower quality study designs in epidemiology, and it sounds like knowledge translation just it's above everything. Like after conducting systematic reviews and synthesizing all the available evidence, then we are producing this knowledge that is really easy to understand and created for users, basically, not the creator ourselves. Yeah,
in a way. So KT is actually really interesting because you can actually apply it at all different points of research. So a lot of the times people, when they think KT, they think what they call like end of grant KT. So a lot of times when you're putting together a project, you'll be like, oh my goodness, I have to disseminate this. Let me present at this conference and I'll write a paper. And, if you're lucky, I'll create a summary for my participants, like a one pager. And so and that is generally okay, good practice for KT. That counts. That is disseminating your final message, and that's good. But to extend it, you can bring on participants earlier in the research process. So that's what we call an integrated knowledge translation approach, or an IKT approach. So actually, I think the exhibit that I'll talk about uses that approach, but that's bringing in the knowledge user at the very beginning. So they actually have a really active role in helping develop the research project, but also helping develop even the research questions. So we as scientists, we always are like, this is the big question that I need to answer, and it's going to do all these amazing things. It's going to have such an impact. And it very well could, because, you are the expert in your field and know the field very well. But unfortunately, it may not have the same impact that we think for the knowledge user. So bringing them in earlier and saying, like, here's what I'm thinking of doing. What are your thoughts? What would help you, or what would you have wanted when you were in, the situation, is actually really interesting and also really telling, and can help refine your research question and narrow it down a little bit. And then that way, when you develop the research project, you actually have a higher chance of getting to an endpoint that makes sense for the knowledge end user. And that will actually help when you decide to develop a project or develop a product at some point that isn't a paper or a poster or a presentation.
Right. So yeah, that makes a lot of sense, because I'm not an expert in knowledge translation. And of course, like the most KT work that I do is, conference presentation and publication, because that's what's required for end of grant KT activities, right? So it's really common, but there's a strong emphasis more and more that we need to produce knowledge that's more for knowledge end users, not researchers, and researchers gather around at a conference and sharing their knowledge. That's not, that doesn't do the work, right? So yeah, really important point. So what type of, so you mentioned that we can create infographic and we can do webinars. What kind of examples do we have for knowledge translation that's beyond publication and conference presentation?
Oh, so many things. So we'll start off with something that's a little more technical. So like guidelines are an example of a knowledge product. And so let's think of the physical activity guidelines broadly. If I think of the version from, let's say, 5 years ago, because I know that there are newer ones, we were told 150 minutes of moderate to vigorous physical activity. And that was great. And then what they realized was that not enough people are meeting this threshold because the definitions are too broad. I know for a kinesiology group, we know what that means. A lot of the times, the students are very active, current or former athletes. Like, we're kind of preaching to the converted at this point. But for a general population person, I always think of, like my grandmother or my parents, 150 minutes of moderate to vigorous sounds like a lot of activity. And then moderate to vigorous, what does that mean? For me, running is quite vigorous, but to a long distance runner, a run is kind of moderate, so how do we define this intensity? So they gave, more, in an updated version, they gave more nuanced definitions. And then I'm just going to fast forward to, what was it, earlier this year or possibly end of last year. Now we have the 24-hour movement guidelines, which I know Dr. Tomarsoni and Dr. Ross, and Dr. Latimer, I believe, all had a hand in developing. So that actually is another example of knowledge translation in action, so to speak, because they developed this knowledge product that was very dynamic. There's a lot of information, but they were able to distill it into move, to every parts of your day. So something like a slogan like that is actually a form of knowledge translation. it's not the most detailed, that's okay, but it's enough to get someone like, oh, what do you mean every move counts every minute, or whatever the slogan is. You know, and there's like the image of like a clock, and so that kind of is relaying that information. The broader guideline breaks everything down into your different domains, incorporates things that are equally important as like reducing sedentary time, making sure you're getting enough sleep. And so that kind of itself is an example of a product. Another example is, so, you know, we're just coming off of the Super Bowl and everything. And I don't know if this aired in Canada, but in the pre-show, there was a commercial about the vaccines. So trying to get more Americans to get the COVID-19 vaccine, because in the US, there's a lot of vaccine hesitancy. So they had this really kind of cinematic, very dramatic commercial, as I think is very common here in the US. And essentially was saying that, you know, the vaccine is there to protect yourself. It's there to protect your neighbors. Get vaccinated, you know, check with your local health units and things like that. And so I thought that was a good broad message. And again, an example of knowledge translation. They're taking the evidence that we currently have. So, you know, we see that we have efficacy, we have initial preliminary efficacy for the vaccine, that it's safe and effective, at least in prevention. We understand now that there are a number of individuals who are not getting vaccinated due to various reasons, whether they be social determinants or logistical issues from their state or their county. And, you know, the end question really is, how do we get more people vaccinated? Well, you know, putting out publications can be helpful. Not everyone has access to New England Journal of Medicine, you know, not everyone's reading that. I don't know why, it's so riveting. But, you know, the average person is not going to read that publication. So distilling it down to this 30-second snippet and the prime messages of protect yourself. It's true, the vaccine does do that, protect others. So we're trying to get to that, you know, we had mentioned in a previous discussion, herd immunity. We're trying to get everyone, as many people as possible, to vaccinated so we can control this pandemic. And then the course of action was to check with my local health unit to figure out how to do it.
Right.
So all of that kind of disseminates from the knowledge that we have. So again, effective vaccines, yes. Hesitancy, yes. And then what do I have to do? And that's all. And if we think about the number of papers, even with such a dynamic situation as the pandemic, that's a lot to disseminate into 3 messages. It takes the KT experts to get there.
Yeah, for sure. And it sounds like you mentioned previously, it sounds like, you know, it requires a lot of collaborative work from different sectors. Like it requires researchers to get involved, you know, like policymakers, government officials, and stakeholders, patient, and you know, administration staff as well. Like, so it's actually a lot of work.
It is. Yeah, it's a lot of work. It's highly collaborative, and it's learning to almost speak different dialects of the same language. Because I will say something along the lines of, oh, we really need to engage the knowledge end user. To an administrator, you know, they are not really sure what that means. If I'm working with an ad agency, they're like, who is that? Is that our target population? And also, I could say, well, actually, the target population for this knowledge product could be a healthcare provider, but the knowledge end user who's going to receive that information is actually the patient. So it's actually different, you know, with different terms. So it's a lot of learning, collaboration, forcing really clear communications. And I'm not gonna lie, it can be a very expensive process because of time and resources, and it takes a while. And actually, the one big thing I forgot to mention in all of this is that KT is actually very much theory driven. So you need to have some sort of underlying philosophy as to why you're making those choices.
Right.
It's not just, you know, willy nilly. We think
just throwing
work. Throwing things and hoping something sticks.
Like, okay, so that's common in afterthought KT, right? Like, okay, what I'm gonna do with my research is, okay, I'm gonna create infographic. Okay, I'm gonna do this and that, right? Like it's not like that. It's integrated in the whole research design process from the get-go.
Exactly. Actually, I can give you a really good example of that.
Sure,
So,
go ahead. Yeah.
Exercises medicine in the US, they have a cancer specific branch.
Mm-hmm.
And so recently in 2019, the tail end of 2019, they had updated the physical activity guidelines for cancer survivors. And they got really into the weeds, which I had appreciated. They created fit principles for various outcomes. So if you are trying to, let's say, reduce anxiety, there's a specific fit principle of engaging in, more aerobic versus resistance exercise in order to get to that outcome. And so everyone was very excited and they said, okay, we need to now create infographics, because that's always our first thought. It's like, let's create a dynamic infographic. I'm not sure why we all this. I don't know if there was like a table kind of read and everyone said this is what we need to do, but scientists, we always want to get there for some reason. And so they created these infographics. They didn't actually engage cancer survivors until the end, and they asked them for feedback. And the infographics, while pretty, were way too much information. It was like a circle to represent the outcome, and then circles underneath to represent the activity. So like dumbbells for resistance, a running shoe for aerobic, and then like a yoga pose person, like stick figure for like stretching and flexibility. And then underneath those little circles, it was like tiny little fonts of here's what you need to do, like here's the fit principle. And so it essentially took, I think a table from the paper and just kind of moved it into like a fun presentation. And so of course the survivors were saying, I don't know what this means. Like I have lymphedema, so I should lift a dumbbell, go for a run, and then get into this weird airplane pose. And how often do I have to do this airplane pose? And so it's since been rectified, and they've brought in more survivors to really offer that input earlier. Partially, so I don't sit on the exercises medicine board, but one of my mentors does, and I've been chatting with her kind of as like a sidebar. And so on my recommendation, they had said, okay, we're actually going to include more individuals because there's an issue here. And what I'm hoping they'll do afterwards actually is translate it, because we have a number of individuals, especially in New Jersey, who are Spanish speaking. We have a lot of Southeast Asians here as well. So translating into like Urdu and things like that also needs to happen. So that's kind of an example of we really needed a guiding framework or a theory to really drive home the work itself, but also our final product.
Right.
Just because you can doesn't mean you should.
Right. So yeah, it's not, developing KT with afterthought is really not a good idea. And actually knowledge translation is becoming a field. It's one research field, and it's called implementation science, right? Yep. So yeah, so there's a theory, there's a framework that we can follow. So before we do anything or plan KT, we need to look at those resources or talk to KT specialists like yourself to plan it really well from the get-go.
For sure. And within implementation science as well, there's also specific approaches that would differ, I think, from even like behavioral and epidemiological sciences. For instance, we do process evaluation. So literally from the start of your research or intervention, you're actually tracking almost everything. Like we have these insane charts of what is said to a participant at what time and the outcome. Did they do what we had asked them to? Did they fill out the questionnaire? Yes. If not, why? And you're literally following your entire evaluation so that when you aren't getting the effect sizes that you were expecting, or there is no significant difference, you can actually go back to your process and see, oh, we may have inundated participants with too many things. They don't need a log, a health coach, a Fitbit, and YouTube videos and whatever else in order to become more active. They really just need the health coach on the log. So kind of going back to your evidence and unpacking what had happened is a very common KT way of
Mm.
developing an intervention. And we have ways for also, including collaborators and frameworks
Mm.
like that. And
Mm-hmm.
it's a lot. It's a
Yeah.
growing field. It's very exciting.
Yeah. The last assignment for students in this course is developing an infographic based on an epidemiological research paper. So that should be interesting.
Good luck. Oh my goodness. Yeah. So don't do a lot of circles
Yeah.
with tiny little prints. I'm not going to tell them how to do it so that they are actually doing the work, but if they Google infographics, they're going to find ones that really resonate with them and they'll understand why, and ones that do not.
Mm-hmm. I know it's difficult because you cannot put too much information, but you cannot put too less information, like, right?
It's
So it's hard.
yeah, it's a what does my primary mentor say? She says it's a science and an art when it comes to
Mm-hmm.
these types of things, because
Mm-hmm.
you don't want the main message to be lost, but you also don't want it to be so oversimplified that the individual doesn't feel the spur in order to continue, like to engage in that behavior.
Right. Yeah.
If I could give another example,
Yeah.
it's not really an infographic. It was actually a blog post, which I
Mm-hmm.
think now is somewhat antiquated. But
Mm-hmm.
so researchers out in Dalhousie were trying to get more parents to vaccinate their children, because, and this is before the pandemic, but childhood vaccination kind of varies, and at the time there was a lot of anti-vaxxers, spilling out a lot of misinformation. So they were trying to promote the health unit in Nova Scotia was trying to promote increased childhood vaccinations, especially for infants. And
Mm-hmm.
so what the researchers did was they actually reached out to mommy bloggers who had
Mm.
really good following and said, can we work together to create messaging that is that will be useful to the moms out there, or I should say parents in general, and inspire them to get their babies to be vaccinated. And so the bloggers came back and said, yes, we can do that. We can help you, but you need 3 messages. That was their whole caveat. They're like, if you can't get it across in 3 messages, simple messages, not crazy sentences or paragraphs, they're like, you'll lose your individual, like you'll lose your target audience here,
Mm-hmm.
or your knowledge end user. So that was kind of the biggest thing from the Dalhousie group was they're like, we have like stacks and stacks of papers where we know the benefits, we know the barriers. How do we then create that? So they actually created a series. It was an ongoing series of posts
Mm-hmm.
that included, understanding the end users, so understanding that their parents, and they may be new parents, they're not necessarily afraid of vaccinating their children, but it's the experience of vaccinating their children. It's
Mm.
actually really traumatizing to the parent to see that their child is screaming in pain, and
Mm-hmm.
the poor pediatrician is like, please just let me do this. And then they kind of came up with, so they came with the messaging like, we understand your experience, these are the barriers that you're experiencing, and they came up with points of action of like, here are some things you can do. So it was I'm probably not remembering it all correctly, but um don't be the one that's holding your child while they're getting vaccinated, because they actually associate it with, oh, mom or dad is holding me down, so this bad thing can happen. You actually step away,
Mm-hmm.
so that they can see that, oh, it's this person, this pediatrician, this scary
Mm-hmm.
doctor that's doing it, and then you kind of come in to save the child.
Mm-hmm.
And then they recommended distractions like blowing bubbles, having like a light toy so they had something to stare at so the doctor could prick them and they would be unaware of the whole situation.
Mm-hmm.
So like they came up with really usable strategies for the parents.
Yeah.
So that's kind of a really good example of a unique knowledge product, but also a way that you can engage. So they had to engage healthcare providers, the parents, and then obviously the bloggers too.
Mm-hmm.
So it
Yeah.
was
Yeah.
a really cool experience.
I think it's really smart to use or get connected with mommy bloggers because they know
Mhm.
their audience, right? Like they're the mommies and
Yeah,
they
and
know
they have the
their
reach, right? Like that was
yeah,
the whole thing
yeah.
too, is a lot of times we talk about research and we're like, oh, we're not reaching the individuals. I joke that the average read for a research paper is 7, and one of them is my mom. And
not a joke, not a joke,
not a joke. She did tell me this. She said it was boring, and she was right. It was. But like, that's the thing. It's like, okay, I reached my mother, who was not the target, was not the end user. And the only reason why she had it was because I gave it to her.
Right.
But that's not good KT right there. I'm literally handing it to her. There's no action. She's the wrong person. Whereas, engaging people who've already engaged the people you're looking for, that's, capitalize on that strategy.
Yeah. I have a hard time with my parents because my parents never know what I'm doing, even though I tell them hundreds of times. So maybe your mom listening to this interview may help her to understand what you're really doing and how amazing you are at your work.
Thank you. Actually, so the way I got my parents to understand my field and what I do is I made them listen to a version of my job talk for my position here at Rutgers.
Oh, nice.
Because I knew if I could get them engaged, like I knew if they had paid attention to me for the full 40 minutes or however long it was, that was a good sign. And then I also knew if they understood what I was saying, then that also was a good sign.
Yeah,
and
nice.
It was great. Yeah, my mom came back and said, I didn't know there was a difference between exercise and physical activity, and that not all exercise is physical activity, not all physical activity is exercise. And it was awesome. And then my dad said, I didn't realize that you had colleagues all over the country. And, I recently had Canadian colleagues move to the US, and he goes, people in California. And I was like, if that's all you took from my talk is the extent of my network, that's good, because I need to convince them that I have a network.
Yeah. Just whatever is impressive.
Exactly.
Yeah. Okay. So, this discussion is, I think, really rich, and I really appreciate, the knowledge that you're sharing right now. So now I want to get into your KT Canada seminar talk. So can you give us what that was about and just an overview? It'll be great.
Yeah. Of course. So for those of you who aren't familiar with KT Canada, it's exactly what it is. It's this overall kind of collaborative network of Canadian researchers and institutions who essentially do KT in some form, but it is mostly directed at health related behaviors and outcomes. There are individuals from everywhere, from like health services, so improving the quality of care and quality assessment. There's health behavior, so essentially what I do, increasing physical activity, increasing vaccinations, healthy eating behaviors, all of that knowledge. And then there's individuals who specifically focus on moving the field of KT forward, so kind of like the founders of the field in a way, who are essentially developing new approaches and frameworks, or refining even current frameworks to make them better, so that more people can adapt them into their research. So that's broadly speaking what KT Canada is. And then every month they have been doing webinars, and this was before all of the whole pandemic situation, because again, everyone is located across the country, and there's a few of us here down south. So because of that, they were like, well, let's have this one time and do a webinar. So they've been doing that for a while, and they invite all sorts of speakers at all sorts of levels, which was amazing. So I was invited actually during my postdoc, and I had said, could we push it until I was in my position, because it was just too much of a transition time for me. But essentially, the talk itself was my postdoctoral project. So I spoke about my experience developing a knowledge translation tool. So the tool itself is an in-clinic guide, which helps oncology care providers discuss physical activity with their patients. And it helps them assess the patient's readiness for physical activity, and then gives them a resource that is appropriate for their current level. And I essentially broke down, I simply broke down how we did that as a team, and just the things that I had learned from that experience. And it was a 40-minute talk, lots of graphics. The one caveat was that, it wasn't working on my end. So the moderator was moving my slides. So in the presentation, you hear, okay, next Megan, because Megan was the one advancing my slides. But yeah, so it's about that project. And it was, it kind of had a lot of elements of knowledge translation. So I engaged the end users. So I was able to get breast cancer survivors who lived in Kingston and were treated in Kingston to be part of kind of our stakeholder group. I engaged clinicians. So there was like a radiation oncologist, medical oncologist, primary care, a GP who specialized in oncology. They were all involved. Unfortunately, we could not get administrative individuals from the hospital on board, but for anyone who's ever worked in a hospital, I think you all know it's extremely difficult. So we weren't going to bat ourselves there. And then obviously included researchers to kind of develop the tool. I will speak to that. You need to find an ideal size for your group. It can't be too big and it can't be too small. And then you have to balance out the power of the group because survivors, may not have the extensive education, so they don't feel as that their opinion maybe is as valid as, say, the medical oncologist who's gone to med school and has X amount of years of experience. But just reassuring everyone that their voices are equal and important is kind of key. And then I essentially walked through the framework that we had used, which was the knowledge to action framework. So the biggest piece there was, again, someone else had done the knowledge synthesis for me, so that I didn't have to do that. But it was, what are the things that need to be assessed by the clinician or oncology care provider, and then what are the resources? So, working with Dr. Thomason's team, her grad students, and getting that list of resources developed. And then, what were the things that we needed to look at? They decided comorbidities were really important for the effects of treatment, and then physical activity capacity. So what individuals were reporting that they could do so that you could further select a resource that would be appropriate for the survivor or the patient. And then, including what we would call like redundancies or fail safes, so that the clinician felt safe to actually say, okay, I recommend that you go to Breast Cancer Action Kingston and do this program. So we would put in, absolute contraindications to physical activity borrowed from the PARMED X, so that if anyone showed or presented with any of these characteristics, we would say, you know what, we can't do exercise with this person. Individuals who are, let's say, had really high, like really difficult comorbidities, like, cardiovascular disease that's not controlled. So, the medication isn't there and things like that, but also had low capacity for physical activity. So walking around the block is too much for them. We had resources like hospital-based rehabilitation that would be appropriate for these individuals because they're supervised, it's one-on-one. And so, developing that list and following that process was kind of what we did. And then we followed what's called the agreed to. So it's this guideline essentially to develop guidelines. And we followed that, even though this wasn't a clinical practice guideline, just to show how rigorous our process was. And that's the other thing about KT is that you really need to show your receipts. You need to say, we either followed this framework or this already established guideline development process, and show at every point that you've met certain criteria. And yeah, hopefully that paper will be out soon. I'm hoping to provide it to your class really soon.
So, well, this is scheduled to be published at the end of March, so hopefully we'll have enough time, and I'll post as soon as it's available. I'll post the webinar with your interview so that students can see, and it sounds like they can really see the entire process of how KT plays a role in the research project that you're running.
I think the KT Canada talk, I think, really distills what I had done. I like to think that it's approachable. There's not a lot of jargon in it, so I hope they find it useful.
Nice. I'm sure after this interview, I'm sure lots of students will be interested in, KT, and for assignment number 10, it'll be helpful for them. So hopefully that will be available before the end of March.
Yeah, I know, that's what I'm hoping.
Yeah. Well, it's been great. I think you brought a lot of important knowledge to the interview today. And yeah, I really appreciate you coming in. Before we finish, do you have anything to say to our students? Any inspiring messages as a new rising star in KT?
Oh my goodness, you are giving me way too much credit. Thank you. I think with KT specifically, don't write it off as something as I just need to use layman's terms to describe the research. It can be quite involved, but don't let that intimidate you. It is a really rewarding process if you bring on the right individuals. And then just kind of a side note, you had said, oh, the pathway for me to get here has been meandering. Yes, it has been meandering. And I think that's really commonplace even for individuals outside of academia. So don't worry about your route that's not perfectly straight and exactly where you thought it was going to go, because you'll end up somewhere that's way cooler than where you thought you were going.
Nice. Yeah, and undergraduate students who are involved in research, they sometimes comment on the impact of research, and they say, like, I really want to do something that has impact to the society, and maybe KT is the right step to get into if they are really interested in making an immediate impact or direct impact from research.
Oh, I definitely think you can. KT may not. So just because you create a knowledge product doesn't mean it'll automatically be approved by the end user and that it'll have impact. But it really does lend itself to having a greater impact. But that is not to denounce other forms of science. Like, we can't have KT without epidemiology, without behavioral science, because we need that foundation. We need that messaging to be clear and consistent before we can say, okay, here's what we need people to do. And I think mask wearing during this time has been a prime example of that, as well as vaccines have been an example of almost what not to do when it comes to KT.
Yeah, so in essence, KT is a masterpiece of our research work.
It's a very important tool in our toolbox, and I think it's one that everyone should access, no matter what field that they're in.
Awesome. Well, thanks for coming in, Dr. Fong. And yeah, thanks for sharing your knowledge.
Of course. Thank you so much for having me, and I really hope that your students gain something useful from our discussion.
For sure. No doubt.
Amazing.
Okay, thanks.
All right, thanks. Bye.